Now, the musculoskeletal assessments are done as per the subjective findings, objective findings, assessment, and the plan. Total musculoskeletal assessment, as in routine assessment, depends first on the patient history and the observation by the musculoskeletal consultant. This is followed by examination of movement, spatial tests, reflexes and cutaneous or sensory motor distributions, joint play movements, palpitations, and after the primary plan of care or primary diagnosis is being achieved, we should confirm it with the diagnostic imaging. And diagnostic imaging can be done when there is doubt in confirmation of diagnosis or different differential diagnoses are present. Now, for the patient assessment, the history should include age, sex, and occupation as a general findings, and that will give us some criteria about their specific categories. Now, most important is why the patient has come for our help. આપણી પાસે પેશન્ટ આવ્યું છે એના માટે the history of present illness or the chief complaints. Now, the commonest chief complaints which are seen in a routine basis, that is the related with the pain, loss of function, deformity, any type of the swelling, and along with that there can be some associated findings like the fever or weight loss or so many things. So most important thing, we must ask to the patient why the patient has come to us, and we have to listen it in a thorough detail. There can be an inciting trauma or macrotrauma or repetitive activities which are considered as a microtrauma. The onset of the problem is slow or sudden, and main important once again after the primary examination of or deciding whether the condition is acute, whether the condition is related with the trauma or not related with the trauma, and listing the symptoms, we have to ask in detail about the most important symptoms. The most important symptoms one again is one of the pain. Now, what you should ask in the pain or other symptoms when patient first had the complaint, how much it was severe, how it was irritable to the patients, whether it was an acute pain, whether it was a chronic pain or it was an acute or chronic pain, whether there was a peripheral sensitization or primary hyperalgesia or central sensitization or the secondary hyperalgesia, how did the pain move or pain spread, what are the trigger points, whether there were the peripheralization of symptoms, means symptoms were increasing in the area, or there were centralization of symptoms were decreasing in area, there was a referred pain, shifting pain, radiating pain, and there is pain during the range of motion. Now, what are the exact movements or activities that cause the pain, that we have to ask in a detail. Pain and its relation to severity of the repetitive stress activity, like pain after specific activity, pain at the start of activity resolving with warm-up, pain during and after specific activity that does not affect performance, pain during and after specific activity that does affect performance, pain with activities of daily living, constant dull aching pain at rest that does not disturb sleep, and dull aching pain that does disturb sleep. These are the primary questions which we have to ask in each and every patient, so that with the history and proper detailing of the pain, we can reach to some important findings. After the pain, the second most important thing is how the condition is lasting, for how many days, whether it is acute, means that it can be around 2 weeks. Second thing are chronic conditions which are longer than 6 weeks, or acute on chronic conditions which are lasting between 2 to 6 weeks. Reoccurrence of the same type of condition is also very important in musculoskeletal conditions, because in early stage patient first feels the pain. If patient ignores or continues with the activities, the things will worsen, and again patient will have the same symptoms once again after the patient is fully recovered. So recurrence of the symptoms, and at the times of recurrence, whether the symptoms were more severe than the previous one, and the duration in between the recurrence is also very important, so that the condition of the patient related with the disease is worsening or improving, that we can judge. Again, this is a kinetic chain system. So The wrist joint problems can affect in the hands and can lead to some affection in the elbow or in the shoulder. So the kinetic change involvement is present or not, that we should ask. After that assessment, which is constant, periodic, episodic or occasional, we will ask how the pain is associated with the wrist, with the activity, with the postures, with visceral functions, at which time of the day pain increases. Pain or activity decreases with the wrist, morning pain with the stiffness, pain or aching as the day progresses, pain at rest and pain that is worsening at the beginning of the activity. Pain is not affected by the rest and activity. Chronic pain. In chronic pain also, fatigue, postures and activity are very important. Like pain occurs at night. At that time, we should ask how the patient sleeps in the bed, supine, on side, prone. Does sleeping up alter the pain? Does patient wake up when he or she changes the positions? Symptoms of peripheral nerve entrapments like carpal tunnel and in thoracic outment leads to be worse at night. Pain and cramping with the prolonged walking can indicate lumbar spinal stenosis or vascular issues. Pain aggravated by sitting and bending forward can be of intervertebral disc. Importance of mattress and pillow is very important when we evaluate the condition for the back pain or cervical pain. Type of quality of pain is patient is feeling. Inner tissues like ligament, joint capsules, bursa exhibit pain similar to muscle pain. But in inner tissue, it is increased when the structures are stretched or pinched. And neuropathic pain should be examined in detail. If we summary the things, pain descriptions and related structures, then muscle will have a dull, cramp-like aching pain. Ligament and joint capsules will have dull aching pain, which are more when the structures are stretched or pinched. Nerve root will have a sharp shooting pain. Nerves will have sharp, bright, lightning-like pain. Sympathetic nerves have burning, pressure-like, stinging or aching, which are very common also in case of diabetic neuropathy and in case of some peripheral neuropathies. In bone, there will be a deep necking, dull aching pain. Fractures will have sharp, severe, intolerable pain, and vasculature will have throbbing and diffuse pain. Along with that, type of sensation does the patient feel and where are the abnormal sensations located. Now, if we ask for a joint specific problems, then it will be joint exhibiting locking, unlocking, twitches or instability or giving way. These are the few words that we can ask to the patient, because it can be a spasm locking, there can be a giving way. Non-pathological conditions, excessive range of motion can be present, which can be laxity or hyperlaxity, and again that can lead to cartilage or have feeling of instability while walking. So we have to ask detail in case of flexibility. Flexibility can be static and dynamic. Static flexibility is related to range of motion in one or more joints. Dynamic flexibility is related to stiffness and ease of movement. Now, commonly how the condition will represent. When patient's inability to control the joint during movement and especially at the end range, which implies instability of the joint. This is a typical finding of the instability. It can be a translational instability like loss of arthrokinematic control. It can be anatomical in case of dislocation, subluxation. Translation instability or pathologic or mechanical instability refers to loss of control of small arthrokinematic joint movements like spin, side, roll, translation that occurs when patient attempts to stabilize statically or dynamically the joint movement. Now, anatomical instability, clinical or gross instability or pathological hypermobility, excessive or gross abnormal movements which are apprehensive at the end of the ROM. Functional instability have both the components of the instability. It can be a voluntary instability, involuntary instability, and there can be a circle concept of instability where due to primary injury to the structures which are doing opposite movement, they can be affected, and all these we are dealing with the one joint examination. When we do joint examination, how the joint stability is there, or abnormal mobility in terms of flexibility, abnormal instability, or there can be a circle concept of instability, damage to some other portion of the joint other than the primary area of the involvement. All are very important when you ask about the detail. Whether patient is having bilateral spinal cord problems, fainting or drop attacks, changes in color of the limb, particularly in case of reflex sympathetic dystrophy and circulatory issues, how experiencing any life or economic stress, because stress can worsen the condition, and psychological assessment is also very important aspect of the history. You should able to judge whether patient is in state of anxiety, or which is very common in case of acute condition, or in case of depression when the condition is very chronic after multiple trial of different consultants or different therapies, patient's pain is not worsening. Again, in that case you have to tackle it in very careful manner. You can ask about the chronic or serious systemic illness or adverse social habits like smoking, drinking, which can influence the course of pathology or treatment. Anything in the family or developmental history is very important. As I already told, that psychological processes can be of attention, cognition, emotion and emotion regulator, and it can be an overt behavior. So while planning for treatment strategy, we should do behavioral experiments designed, for example, to confirm unrealistic expectations and catastrophizing. Positive psychological techniques that promotes well-being and positive emotions, and coping strategies and training we should design for different patients, so that we can satisfy the patient as a overall after understanding the patient's psychology. After that, we can prescribe X-ray examination or imagings. We should take the history of analgesics, steroid or any other medications, or history of past and present surgeries or illnesses also. So history taking is one of the most important aspect. After enumerating all these conditions, you can plan in which area the patient is suffering, and that will give you the preliminary working diagnosis. Now, if we stretch it just to complete the knowledge regarding the history, examinations and that, the most important things which as a clinician you must know: the pain which is drawing and pain which have some adjectives, symptoms of pain, numbness, weakness, time pattern and response to treatment, signs like tenderness, axial loadings, simulated rotations, trach leg raising, motor and sensory. This will give us some idea about the illness behavior, particularly in case of back pain. So these type of specific assessments are also made, and that will be told to you in the subsequent lectures. Now, what is the observation? Observation is to gain information visible to us without asking to the patient. Whenever the patient enters in our cabin, patient sits, patient goes to the examination table, how he sleeps in the examination table, how he comes down from the examination table, how patient walks. These are the findings, these are called the observation findings. So many a times our teachers also said that the diagnosis can be confirmed in common conditions when the patient enters in the OPD by observing the patient's posture, gait and the first few words which patient tells to us. So observation for posture, manner, attitude, willingness to cooperate or any signs of overt pain behavior is very important. And overt pain behavior can be differentiated into the guarding pain, bracing pain, rubbing pain, grimacing or sighing pain, which will give us about the idea how the patient's condition is severe. We should observe and compare both the sides. We should look, does not ask or does not palpate. We can ask about asymmetric, what is normal body alignment, what are the form of restricted range of motion like flexion deformity, malalignment, alteration in shape of bone, alteration in relationship of two articular structures, structural deformities, functional deformities and dynamic deformities. bony contours of the body which are there normal or symmetric, any soft tissue contour which are normals or asymmetric, obvious muscle wasting, limb positions equal or symmetric, pelvic position which is very important. You must examine the patient for the neutral pelvic positions, and definitely the hold the neutral patient positions or patient control dynamic neutral pelvis. The color and texture of the patients indicate the recent injury or surgery, any crepitation, snapping, abnormal sound of the joints when patient moves, any heat, swelling or redness, what attitude does patient to have towards condition or toward examiner, either it is apprehensive, restlessness, resentful or depressed, patient's facial expression and willing to move. So this we have concluded as far as the findings which are concerned in history and observation. Here we have not, this is the first step. There are 5 or 6 steps to confirm a diagnosis. But if patients can be diagnosed early, that is a sign of a good clinician or good physician. He should not miss each or a single aspect in history and observation so that the rest of the life becomes easy.